Welcome to the Betty Rocker Show, the place to be to nourish your mind, love your body, and rock your life. What's up, rock stars? Coach Betty Rocker here. Hey, thanks so much for joining me. My guest today is Dr. Jill Carnahan, a frequent guest on this show. You may have heard her before. She is dually board certified in family medicine, a practitioner of integrated holistic medicine, and is also a functional medicine expert. She's the author of Unexpected, a very inspiring read, and she's also the subject of a documentary called Doctor Patient. She's got a fabulous podcast and a really, really helpful blog, just packed with great free content you can access anytime. And as a survivor of breast cancer, Crohn's disease, and toxic mold illness, she brings a unique perspective to treating patients in the midst of complex and chronic illness. She's the medical director at the Flatiron Functional Medicine Center just outside of Boulder, Colorado, and my own personal doctor. And I always feel really lucky to get to work with her and also to be able to share her with you guys because she really helps make sense out of so many complex health-related subjects that are relevant to us all. Please join me in welcoming her to the show. Great to see you, Dr. Jill. Thanks so much for joining me today.
You're welcome. So good to be with you again.
Yes, it's always great to get to check in and have a conversation. And one thing I feel like has been on my mind and on the minds of many of the women I serve is this conversation about menopause, perimenopause, and postmenopause, right? The all-encompassing menopause umbrella. And it's great to see menopause having its day. I feel like finally we're hearing more about it. There's a lot more research than there used to be. And when I think back to our conversations maybe early on in my own perimenopause journey, I think about how much anxiety I had about hearing about things like bioidentical hormones or hormone replacement therapy, and how that conversation kind of evolved and how much more we know these days. Why are people still, I feel like there's still a lot of fear around hormone replacement therapy though. I mean, just to get us into it, like, where's that come from?
Well, it actually comes from our profession, and I'll tell you the story and it'll make so much sense. So I graduated 2001 and got out of medical school, and that year was the year the Women's Health Initiative first came out in the news. As the researchers are compiling the data, the news took this information before they even finished compiling and said, oh my goodness, is there an increased risk of breast cancer with hormone replacement? And literally hundreds of thousands of women stopped their hormone replacement because this media took this story, put it out there. And even as a doctor, that was the story that we were told. So we all started, this is 20 plus years ago, being afraid of this. What happened in that 20 years since is they analyzed the data in that largest randomized controlled trial of women on hormone replacement, and the data came out very clearly. Number one, there was two arms. One was an estrogen only arm, and they used Premarin, which is actually a horse estrogen, not even the best, cleanest bioidentical, but it is an estrogen. And the other arm was a Premarin, which is an estrogen, plus a Provera, which is a synthetic progestin. I'll explain that real briefly in a minute. So these two arms, the first arm came out, and this has been the last analyzed research, well documented by anyone who's looked at this. There was actually a 34% reduction in breast cancer in that arm. So not only was it not neutral, like just or harmful, it was actually a reduction. And we've known for all of this time that hormones, especially estradiol, helps the brain, the bone, and the menopause symptoms dramatically, and the heart. So those things were never questioned. It was only this question about breast cancer. Now, in that other arm, here's where the controversy came in. They had this slight increase above baseline with the Premarin Provera arm for breast cancer incidence. But what happened is what they were going against as the baseline actually had a higher incidence of normal, so it skewed the data. And the second thing about that was, as I mentioned before, this was a synthetic progesterone. It wasn't progesterone at all, which can actually mimic progesterone deficiency in the long term because it hits those receptors, but it's not a natural progesterone. So neither of these trials, even though they showed a decreased risk of breast cancer, were even using the kind of hormones that you and I are talking about, which is the exact same as our bodies, our ovaries produce. So I confidently, and you mentioned before, I'm a breast cancer survivor. So I am 20 plus years out. And for me, this is a very personal issue because here I am in menopause and I'm like, what is safe for me? Because I've had breast cancer and I can confidently say without a shadow of a doubt, I used to think we had to choose. We don't. I think as long as you have a good practitioner who knows what they're doing, you're checking levels, and we'll talk about all that today. This is a huge issue for women, and it's going to affect bone, brain, and heart in a good, positive way. And now we think it may even be protective against breast cancer.
I've been reading that data as well, and it's great to hear it from you. And part of why I wanted to ask you that question to start us off is so that, that you would share that if you are a breast cancer survivor, it is something that is so deeply personal to you. I know that there's no way that you would have prescribed that to me. You wouldn't have prescribed hormone replacement therapy to me or to numerous other patients you've served if you thought there was a risk for us. Now, of course, there are going to be some people who it's contraindicated for. There's certain things as a clinician, I'm sure that you look at. I'm sure that there's the blood clotting factor. There's all of these different things that we want to watch out for. And that's something that when someone's individually working with a doctor, they need to care about. But I think it's really important to just, even though that was, to me, that was a little technical what you shared. And if you're listening and you're thinking, I didn't quite follow everything she was saying, but you understand the data as
Mhm.
a doctor who reads the science, you understand that it's safe. That's
Yes.
basically what you're saying. And like that these studies in some ways had some real flaws. They were
Yes.
studying forms of hormones that we don't actually use in women's medicine. And also that so there's all this fear around it, and it's not for everyone either, right? Like I
Right.
know we're not going to say, oh, everyone needs to be on
Yeah.
hormone replacement therapy, but
If you're
since
undergoing breast cancer treatment, for example, I would not give someone hormones during treatment. So that's a very clear
that's a
contraindication.
right, so there you go, there's a reason not that, and there are probably some other reasons too, and yet it should be an accessible, viable option that women have access to, is all I'm saying, without all the fear. And that's why I wanted to just start us off talking about that, because if we're going to get into some of the viable treatment options for women in the menopause years, it's important to know that we've thought about this first and foremost, because I think safety, women's safety, and their access
Yeah.
to healthcare options is really important. It's essential
Yeah.
at every age. And this is an age that I feel like has been overlooked, has been ignored, has been too long, just sort of like, you're just getting old. I can't tell you how many women have written me, and you've probably seen this in your practice as well, saying, I've been dismissed. I've been told I was depressed. I've been put on anti-anxiety medicine. I've been told I need to just exercise more and eat less. I've been told I'm just lazy. It's all in my head. I've been put on birth control. Like all of these different things that are like getting at symptoms, but not really addressing the root cause, which is this shift in our hormones that
Yeah.
happens. I don't know. It's just,
So true. And I love that you said it's even today, every day in my practice, I have these discussions with women, and there's some who choose not to. And that's okay too. But every woman deserves a discussion with an educated provider. And if your provider is absolutely no, and there's no discussion, then you want to find a different provider because it isn't for everyone. And there's
right.
a very important choice. And if you have a lot of anxiety or fear, I never push anyone. So there's still, I maybe 20% of my women that we talk about and they don't go on hormone replacement, and that's okay too. But to have the option and to
The
know
choice, you
the
said
choice.
choice. That's the word.
Yeah,
That's
yeah,
it. And the education about it, to
yeah,
know that you can make an informed choice for yourself, to know there are risk factors for certain people, and then
yeah.
some of us there aren't. Well, let's talk a little bit about the stages of a woman's life that we go through. There's the perimenopause years, those years leading up to menopause, the event where our period stops for 12 months, and then we're in the postmenopausal years. So there's really perimenopause and postmenopause, and menopause sort of like defines that cusp where we go to the next level, as we call it, right? And so there are women who come to you at these different stages of their menopause journey, and they want to know all kinds of things like, well, how do I know I'm in perimenopause? How do I know what should my hormones look like at these different stages? And I would imagine that those are the kind of things that you help address in your practice. So if someone comes to you and says, I think I'm in perimenopause, or I'm having these weird symptoms, what do you test for, and what kind of symptoms do they show up with, so that maybe we could help someone out there who's maybe struggling right now or trying to figure out what to ask their doctor?
So commonly, women as young as 35 can start to experience these perimenopausal symptoms, and usually from 35 to 45 is that realm. It can go as long as 55. I think the average age of that menopause date is around 52, 55, and then after is post. But this can again be almost a 20-year span from 35 to 55 that some women struggle. So one thing I'm a fan of, and not all doctors do this, is testing. I use blood, urine, different types of things to assess different things. And this is a whole nother lecture worth of material because depending on if you're using a cream or an oral or how you're doing it, certain tests pick up things differently. And that's a whole nother discussion. But it's important that you have a doctor that will assess where you're at because you have the symptoms typically. And the symptoms can, for example, in that early part, so say 35 to 45 or 50, often you start to first have a lack of luteal phase progesterone. That's usually the first thing that drops. So you often experience estrogen dominance, and hormones are all about balance within one another. So if we have our cycle, follicular phase estrogen goes up, second part of our cycle, luteal phase progesterone goes up, and that just yin and yang happens all through our 20s and 30s. Well, in our late 30s or early 40s, what starts to happen is that progesterone will often diminish production. So you have this dominance of the estrogen throughout the cycle that can cause breast tenderness, moodiness, heavy, painful periods, endometrial pain, endometriosis, fibroids, all these kinds of things. And that can be a symptom in and of itself that can be treated with natural progesterone or sometimes herbs that will increase the luteal phase progesterone. And that's usually the first thing. Then somewhere in there, your ovaries start to sputter. And I always say it's almost like if you had a bottle of Heinz ketchup and you're squeezing out the last bit, and then the hormones are starting to go, just kind of like this little
Just
this
petering
mess
out.
of a spurting out. And sometimes you'll have a day that's high and low and high, and you can't figure out what's going on. And even testing, you have to be careful because if you're testing that period, you test 1 month, you might have high estrogen, low progesterone. The next month it might be low, and it just does this dance. And that's the time when women are so frustrated because like, I don't feel well. What's going on? They might start to have hot flashes, but they're still having heavy cycles. And so in
Right.
that window, women can still do bioidentical hormones, but it's important to have a clinician that knows how to assess the symptoms related to what they're likely experiencing hormonally, and then also test, knowing that the test can be up and down. And in that
Yeah.
phase, it's going to be like the Heinz ketchup spurting out randomly. And then you get to a point where those ovaries just like, I'm done. And that's when the estrogen starts to really drop. And this is when women would start to have hot flashes, night sweats. All of a sudden, they cannot remember names, places, where they put their keys, where they're going. They get in the car, like, where am I driving to? Like things where they literally, women have come to me and said, I think I'm losing my mind. They can start to have this, like, you and I have been driven women in our field. And I know when I first hit menopause, I'm like, the overwhelm, the feeling like I couldn't handle things normally is really common with women because they're driven and they're doing well. And the estrogen really helps our brain stay on track. And
Mhm.
when that drops, we're like, oh, wait, my executive function, the planning, the executing is impaired. And I'm like, I feel like I'm losing my mind, or that the things that I used to be able to handle are harder.
Mhm.
Emotionally, you're up and down. You may be more tearful one day, more angry one day, more sad. Don't want to get out of bed one day. And when none of those things were there before. So I love talking to women because so many women literally feel like they're going crazy if no one validates this. And it's a normal experience, but it can feel so disorienting. And even the data, as far as broken relationships and divorces in this time, it's not surprising that that goes up because women feel like they're going crazy. And most men and many doctors gaslight them into thinking they are going crazy. And it's just their hormonal transition.
So I hear you saying that there are these real distinct phases of perimenopause that we go through. And this is why it's harder to pinpoint sometimes because it's a moving target as we
Yes.
go through these years of our lives. And it's surprising to hear you say that it can start as early as 35, but it also makes sense, right? And I guess you may not know exactly where you are. It may not go exactly with your age, right? So if we stay on the perimenopause conversation for a minute, say I'm a younger woman, or say I'm like 40 years old, and I
Mm-hmm.
come to you and I say, I think I'm in perimenopause. What would you specifically test for? I can remember some of the things
Yeah.
you tested me for specifically when I came to see you. And of course, I had complex symptoms and many different things going on. It wasn't just menopause when we first started working together. But I do remember that over time, you've tested me for some specific basic things to
Yes.
help see what if it was perimenopause. So would you share a couple of
Yes.
those?
So one thing is this can be done at any conventional lab. And even though blood work isn't always perfect if you're using like a cream or whatever, it's a great place to start. It often will be covered by insurance. And what you'd want to do is a basic panel. Estradiol is the main E2 estrogen, and you can get estriol and estrone, but just estradiol is a good place to start.
Just to
And
say,
now,
just she said E2 and then she said all those things. So that's E1, E2, and E3. There's three types of estrogen. So estradiol is E2, and that's the one you want to know about, right?
yeah, that's the main one. So again, it's
Yeah.
great if you can get them all, but if you just get one, get estradiol. And lately, the lab now has a highly sensitive estradiol. So HS or highly sensitive is better because this is very, very, very tiny parts in the blood. So they're measuring little tiny things, and it gets a little more specific and sensitive with that highly sensitive estradiol. You
Do
want to
you
get
have to get a
progesterone.
special test to test for that? Does your doctor
No,
have
this
to?
could be just a regular LabCorp Quest, regular
Oh,
hospital
cool.
lab. Just writing estradiol on the lab order would do it.
Okay, good.
Yeah.
Good to know. Okay,
And then
sorry to interrupt. I
that's
just want
okay.
to make sure there wasn't something special we had to ask for.
Yeah, no estradiol, and then progesterone also critical because we always look at the ratio. Just like we said, these two
Right.
are the dance partners, so we're checking those two in conjunction. If I have a choice, I'm testing all these, and I'll continue with the rest of them on day 19 through 21 of the cycle. So that's assuming you have a typical 26, 28-day cycle because that's going to hit your luteal phase, and what you're going to see there is if the estrogen and progesterone are in balance. So that's
Right.
the timing of what you might do for this. So estradiol, progesterone. DHEA-S is how we test DHEA, which is another steroid hormone in the blood. Testosterone, I like to get both free and total.
Hmm.
And then cortisol in the morning, because that's kind of a standard, although you could get it randomly through the day. And if you just get those five, estradiol, progesterone, DHEA, free and total testosterone, and cortisol, you're going to have a pretty good idea. Now, you can get fancy and get something like DHT. This is a very potent steroid hormone like testosterone that can cause hair loss or can cause acne or PCOS, but you don't need to get that fancy. If you just get those main five, that'll give you a good map.
And I remember that's that basic panel I've had repeatedly, and I wanted to touch on that because so you've had those tests done for me multiple ways over time. So in the beginning, we would do a combination of the Dutch test, which is a urine
Mhm.
test that we do on those very specific days of the luteal phase of the cycle. And you need to be tracking your cycle in order to know where you are and when your luteal phase is. And I find that it's actually really helpful to be tracking your cycle when you're in perimenopause because it's going to give you some indication of knowing as your cycle starts to get erratic. It's easy to just forget about your cycle. Honestly, I often would forget I was even going to get my period in my regular cycling years because
Yeah.
it was just so like, I would be like, oh, this again. Right, right.
Yeah.
I wouldn't have much
Me
sense of
too.
it. Right. So, but now, like in perimenopause, it's been really helpful to track it, to have a sense of it. And I, of course, I'm wearing my Aura ring, and that really helps me because I can see my basal body temperature go up when around ovulation and it stays elevated through that second half of the cycle. But anyway, back to these tests. I would typically do that Dutch test. You would order that Dutch test for me, the urine test. And then I would also go fasted first thing in the morning, early morning, and get a blood test as well. And that was where you were checking that T3, the free T3, the free thyroid hormones, right? The free T3 and T4. One of them's free. I don't
Mhm.
remember, but
Yep.
T3 and T4. And then you'd also be checking the fasting cortisol in the morning because we'd want to see like
Yeah.
where that was. And then we'd also I think you could see things like testosterone and you could see the other hormones.
Mhm.
But it was the combination of that with the Dutch test that together gave you a much clearer picture of what you wanted to see that would help you see if my hormones were in balance, how out of balance they were. We started to see over the course of the few years that we tested these two things back to back, the blood and the urine, how my hormone levels really went down and down and down.
Yeah.
And I remember in the beginning, I was able to get by with simply using some adaptogenic herbs that really helped support my stress response and helped nourish my hormones. And I was able to feel better, even though it didn't really make my hormone levels go up much. I
Yeah.
felt a lot better and it reduced a lot of the symptoms I experienced. But then as I got a little farther into the perimenopause journey, it became really essential for me to start using things like hormone replacement therapy. And then I feel like I'm maybe in the end of that middle stage of perimenopause now. I'm like using a combination of different types of hormone replacement therapy. I have some props here to show you guys in case you're watching this on YouTube. I've got my patch. So I
Mhm.
use this little patch and I'll just open up the little foil packet so you can see it. It's just a little sticker that I put on, and you change it every few days. Or Dr. Jill had even given me some recommendations, as I'm very sensitive to a lot of this stuff, where we tried it for a longer period at the start to see how I responded, and then we tested again a few months later. And I've also got some different creams, topical creams. She in the past had me try an oral progesterone, and we found that for me personally, the typical recommendation was, I think, to take it at night. My body didn't like that, so I
Mhm.
took it in the morning. So there's just all of these fine-tuning, sort of
Yeah.
nuanced aspects of this. And then there's also a pellet, which I know you recommend in very specific situations, but if you got a pellet injected under your skin, which we talked about in another podcast, you can't change that. It's
Yeah.
there. You can't take it out easily yourself, right? So it just got to do its thing. So it's less customizable. Whereas with the creams, you can do 2 clicks, you can do 1 click, you can really control your dosing, I think, really, really well. Those are all things that I've experienced based on the testing. And I will also say that you and I tested a good amount. Like it would be
Yeah.
a few times a year we would
Yeah.
test to see
Like every
both.
3 to 4 months. It was
That's
great.
right.
Yeah.
Yeah, absolutely. To see like how did my body respond to the treatment. We wanted to give it enough time for it to have some effect. And we wanted to then see how was the body doing with these things. And then if something responded, we could see that. And if it didn't, we could adjust my dosage. But we didn't just go really fast
Yeah.
into things. We had to like take, and that can be a little bit of a process, right? Like, because you want results immediately, but if you overdo it, you can feel worse. And
Yeah. Like
that's
you don't
something.
want breast tenderness with the estrogen, which is the use typical. And one thing a lot of people are worried about clot risk. And what if I have this? There's different gene things that you might have been told
Leiden
by your doctor.
factor five
Yeah.
Leiden, right? Like that's in
Factor
my
V
family.
Leiden.
Yep.
Yep. Or certain other ones out there. And so if you've been told that's a risk, the deal is oral hormones, especially estrogens, do increase the risk of clot. It's why you will almost never see me prescribe oral estrogen because I don't want to even go in that category, right?
Mhm.
Transdermals do not have the same risk. Transdermal just means a patch or a cream or something you apply to your skin. Our skin absorbs hormones really well. So
Mhm.
I almost exclusively do the compounded creams that you showed or the patch that you showed. And there's different ways to do those, but those are really great and safe ways to apply. Now, you mentioned often doing blood and urine at the same time. The Dutch hormones is what you mentioned. I typically, to follow the hormones, like to do the Dutch because in the blood, you won't always see the true levels of a cream or a patch.
Mhm.
So I sometimes do both, like we did with you. If I have a patient who's willing to do both, that's the best. But you can see the differences because if you're really following a cream or a patch or a protocol, your Dutch urine test is going to show more the accurate levels of your body versus the blood.
That's super interesting. So if someone were just trying to follow their hormones, if they could just test kind of consecutively, maybe not every month, obviously, but like on a decent basis, maybe every 3 or 4 months, they would use the Dutch test as their primary to see if they were doing hormone replacement therapy. Now, you
Yes.
mentioned compounded. That
Yes.
that's so there's a couple of different types of these transdermal or cream-based
Hmm.
hormone replacement therapy types. Do you want to speak on that a little bit? I feel like there's a lot of
Sure.
you hear about HRT, you hear about
Yeah.
BHRT, you hear about all this stuff. So tell us
Yeah.
about the differences there.
Sure. And just to reiterate what you said
Yeah,
about testing, my standard patient, we might start them on a protocol, and usually about every 6 months is kind of when, sometimes sooner if they're having symptoms, but on a routine. And at the very least, I'm going to check them yearly. So
sure.
everybody who gets hormones is required by me to do a yearly test so I know, and sometimes more frequently if we're changing doses. If they're really stable, yearly does pretty good. Like I'm at a
Sure.
place now I do once a year and I'm stable on doses. So what is available? So there are regular pharmaceutical prescriptions you can get at CVS, Walgreens, or your regular pharmacy that are bioidentical hormones. Estradiol, as we already mentioned, is the main hormone that you're going to see, and this can be prescribed as a cream, as a foam like roll-on, as a patch, which is my favorite, most common because women don't have to think about it.
Yeah.
So there's lots of different ways, and that is only one. It's the E2, the estradiol, that's the most strong. It works. It's a great way to do it. But a lot of times women want to have a combination, and we can prescribe compounded estriol, which is that weaker form of estrogen. And for example, if we have someone who has recent breast cancer or very, very concerned, estriol is kind of a caboose estrogen, meaning end of the line, and the body doesn't take and make other things with it. So it tends to be the safest, even among oncologists, with someone being treated for breast cancer with vaginal dryness, they would say, oh, this type of estrogen is really safe. So if you have any concern, you can always compound these. And often I'll do either 80-20, meaning 80% one, 20% another, or 50-50. And you combine these two, estriol and estradiol, into a cream. And because you can compound it, I can start with much tinier doses for someone who's really sensitive. And you can also put progesterone in that cream. So many of my women have like a biest, meaning like two types of estrogen with a little progesterone all in one, and they use a couple clicks on their skin at bedtime or morning. So it can be pretty easy to do, but that way I can actually pick the exact dosages for that individual patient and adjust it based on their results with fine tuning.
That's so cool. I love that. I feel like I've been having my own little apothecary over here, and
Yeah.
I can see that my estriol, estradiol is a combo, and I have a separate progesterone,
Mhm.
and I also have my little testosterone,
Yes.
and that's been, I feel like, really helpful.
Yes.
You want to talk a little bit about that because we don't often talk about testosterone, and
I
tell us
do
about
because
that.
I get so excited about testosterone. So this is, we think of it as a male hormone. We
Yeah.
have testosterone lower than men, but we have testosterone. We need testosterone. It helps our bones. It helps our brains. It helps our motivation. It helps our body composition. Women who are deficient in testosterone, it's one of the reasons why there is 4 times the incidence of autoimmunity in women as there is in men, because that lower testosterone actually increases risk of autoimmunity. So there is, I have even used off-label testosterone as part of a protocol to treat autoimmunity because it's so
Wow.
powerful in women. So I'm a huge fan. Now, you don't want excessive, but getting the right dose will literally change your life, your mind, and all those things. In addition to the estradiol libido for women, it
Mm.
absolutely has an effect to vaginal dryness. And like I said, bone and brain are huge with testosterone. So testosterone can be given as a, we almost never want to give a pill where you swallow because your liver has to process estrogen, testosterone, whatever. We don't want to load up the liver. So I'm always trying to bypass the gut with hormones. That's either a cream or a patch. With
Mhm.
testosterone, there's a couple ways you can do it. You can do a cream, but for women, wherever you apply that cream, inner thigh or wrist, you're going to get a little hair growth. So a lot of women don't like that. And so instead of doing the cream, I will often do a troche or a sublingual tab that dissolves under your tongue so that you get that dose without getting into your gut and through the liver. A lot of women do injectable. Now, it used to be that the commercial forms were only for men, so to get the tiny doses that we needed were really hard to draw it in a syringe. But I do find, well, now we can compound it like women concentrations. And I do like, as long as women are afraid of doing an injection once a week or once every 10 days, that is a great way. It typically does give a level that kind of goes up and down every time you inject. So you have a little bit more variation than you would with a daily dose. So testosterone can be cream. It can be in troche or an oral sublingual, and it can be injectable. And those are the main ways. And because right now our pharmaceutical industry is geared towards men and testosterone, most of the commercial, if not all of the commercial ones, patches, creams, even injectable, are typically made for male dosing. So this is typically compounded for women to get that dose.
And you and I have found that my body just loves that. It just has really helped me a ton.
Mhm.
And I've taken such a tiny dose
Yeah.
over the time that I've been using it. It's been really helpful, I feel like, for balance. And then I also take the oral DHEA supplement to help because that's of course a precursor to is estrogen and testosterone, right? It's a precursor. It supports our adrenal production. Um, as- and that's something that I always so found really interesting is that because, of course, we're making our estrogen and progesterone primarily in our ovaries, but we also make some hormones in our adrenals, correct?
Yeah. Yes.
And if our adrenals get overwhelmed by stress, the stress response, it's going to be harder for them to make some of those backup hormones. And I remember a really interesting conversation you and I had a while back where you were like, you see women who have a really robust adrenal function have an easier time in going through perimenopause
Yes.
because they are not strapped of the backup hormone system almost. Did I say that right? It's
That's exactly right. Because when our ovaries conk out and they're like, I'm done, I'm
right.
retired, right? Which is what happens when we hit menopause. The ovaries stop producing the hormones, our adrenals take over. So we still do produce a little bit of hormones from the adrenal glands after menopause, not nearly as much as ovarian. But if those adrenals are so taxed because you've been working 80-hour weeks and not getting
Yeah.
sleep and taking care of your parents and your children and all these generations, then it's really common to have a much more difficult time in
Right.
menopause. And I love DHEA. First of all, it's the only one of these that isn't requiring a prescription. The rest of these, you do need a
Right.
prescription. And just for the record, testosterone is still considered controlled, whether it's athletes or there's some things that so that is one of those that you can still get a prescription, no problem, but it's in the category of controlled prescriptions. So you might have to get a lower amount, like 6 months versus a year or certain things.
Mhm.
But DHEA is available over the counter, and women often do well on 5 or 10 milligrams, upwards of 25, but that's a pretty high dose for a lot of women. And what can happen there is that will support your production of cortisol. If the adrenals are low and you're low cortisol, it'll support testosterone and DHEA. So it's kind of a nice adrenal support if your adrenals are in a weakened spot. If you're really high cortisol and you're prone to breakouts, those are the kind of people I probably would not put on DHEA, because then you raise the cortisol and you may have some more breakouts. But usually women will know because they'll take 5 milligrams, which is a tiny dose, and they break out. So stop the DHEA.
Right. Uh, I think this is a good opportunity for us to shift a little bit to the postmenopausal conversation. I want to talk about everything all at once, everywhere, of
Yeah.
course. But I'm really interested and curious because I'll be in postmenopause soon and I want to know what to expect. And I've got a lot of women who listen who are in postmenopause and they want to know, well,
Mm.
what should, is there something, what tests should I get? And then what options are there for me? What should we do and how can we help them?
Yeah, so there's basically 2 or 3 ways this could happen. We talked about, like, say you're 35, 40, 45, and you're starting to have symptoms and your doctor is open and you get some prescriptions. You can actually go through this very smoothly and then hit menopause and kind of have been on hormones.
Sure.
But what you're talking about, I think, is, say that woman out there is 65 and they have never been on
Never.
hormones,
Yes.
right?
Right.
And they're like, well, what about me? Well, first thing is, Dr. Dale Bredesen does a ton of research on Alzheimer's, and
Who's
he's
that?
one, Dr. Dale Bredesen. He
Okay.
wrote the book End of Alzheimer's, and he's one of our researchers and leading experts in dementia. And I mention this because in his protocols, there's a type of Alzheimer's that's related to lack of estrogen in the female brain.
Wow.
So he is putting 85-year-old women on hormone because it's so crucial to our brain function. And so this old myth was that, oh, after 65 we don't need hormones. So if we're on hormones, we stop at 65, or if we're above 65, you're too old for hormones. That is not true. Our brains, till the end of our life, can use the hormones. Now, maybe at some point you need lesser doses, but I would say to any woman who's postmenopausal and maybe having symptoms, maybe not, I would still start with testing and then
Yeah.
talk clinically about symptoms and then talk about safety. Safety is the same thing here, but what happens is, say you went into menopause or you hit menopause 55 and you've been without hormones for 10 years, your receptors start to atrophy and shrink up. So what happens is, when you first start hormones, if you have never been on them, there's a little bit of adjustment because you may not either be able to sense that hormone well, or you may very quickly get flooded with too much. So it just takes a
Right.
practitioner who's careful with that. But they're truly, with heart, brain, and bone, there is no age too old that does not benefit from hormones, as long as there's a conversation and all of that
And it's
happen.
approached carefully. That makes total sense. And I'm so glad you said that. Some of the telehealth sites that help women with balancing their hormones post-menopause, they say that they're not going to prescribe if you've, or there's some wording about if you've been 10 years without having a period and you have never been on HRT, like they want to check in about that because of exactly what you're talking about. Like these receptor sites sort of are, they atrophy, like you said,
Yeah.
but that there still could be that you still could have that opportunity. So say someone came to you and she's just like maybe a few years into postmenopause. What would you test her for? What would you be looking at? Would you look at, I mean, you probably still want to see like what her levels of estrogen are like. You probably want to check her cortisol. I don't know, what do you sort of look at to help her? And obviously it's
Yeah.
individually based as well, but if she's interested in some type of hormone replacement therapy, I guess what conversation and how do you test?
Yeah, so we'd still do probably blood work or Dutch hormones, one or the other or both. And then what we'd want to do is there is a risk of if you have uterine fibroids that are unchecked and very large, or you had severe endometriosis. So any of the endometrial diseases, this means like the lining of your uterus was abnormal or thick, or you have these growths that are benign growths, but they're stimulated by estrogen. Those conditions could be stimulated even by healthy bioidentical hormones. And fibroids are benign, but they're a pain. If you have them, they're large, they're uncomfortable. They're
Yeah.
typically not malignant, which means like they're not cancer, but those are caveats or things that as a physician, I'd be very concerned or have a discussion
Mm.
about. And also, if you are perimenopause or in those earlier years, 40s or 50s, and you have had a massive issue with fibroids or endometriosis, those are discussions we want to have about how to dose this and be watching that carefully. So
Mm.
typically a woman who's never had any hormones, I would screen them with a pelvic ultrasound to just
Mhm.
look at that pelvis and make sure everything's safe. Because if they have fibroids, those could grow with hormones, and you have to know that and then be able to watch it. If any woman has breast tenderness with these hormones, that's a sign. I'm always like, oh, that's you're hitting your threshold. We probably should lower it. So that's like a warning thing. I'll say you don't want to have breast tenderness, or if you do and it's just transient for a week and it goes away, that's probably okay. And then the third thing is if you ever stop bleeding for over a year, that's technically the definition of menopause. You've gone into postmenopause, and you start to have bleeding after that year without a cycle. That requires you to get an endometrial biopsy and a workup to make sure your lining is not getting too thick. And these are just those careful things that a good doctor would do if you're on hormones, because hormones can cause that lining to get thicker. And so if you have a high risk of that or some reason, you'd have to have that discussion about safety and efficacy with your doctor. But I would always do a pelvic ultrasound and check their clinical history and then talk with them carefully. I would also probably start a 70-year-old woman at a much, much, much lower dose than I would a 45-year-old woman.
Sure. Thank you for sharing that. And that's so helpful to know as we go into these things. We want to have our eyes open about risk factors. And you mentioned that you do a Dutch test as one of the options for a postmenopausal woman. But since she isn't having a cycle anymore, when do you
Yeah,
do that?
anytime.
Since you can do it anytime.
Anytime. Mhm.
Right,
Yeah.
right. Because you're just looking to see where her levels are at so that you could determine. Now, and then for someone who's postmenopausal, are you going to be putting her or an individual as anybody, I guess, would they be getting on a similar protocol to what someone in perimenopause is getting on? Are you going to be giving them all the same types of hormones? Would they need all of them? Or are they more likely to be just getting on an estrogen or maybe some testosterone? Or is there a reason to still add progesterone? I'm just so interested.
Yes. So the typical medical training is if you have a uterus and you use unopposed estrogen, meaning all you get is estrogen, that's a risk for that lining being thicker and actually developing endometrial cancer. So we as
Mm.
physicians who are doing good work would never give a woman who still has her uterus unopposed estrogen by itself. You would always give it with progesterone. Progesterone protects you from having that. So whatever age it is, and if I think of order of operations as far as safety and even from 35 on, what we would do, progesterone almost always comes first for
Mm.
many women because many women from 35 to 45 do really well with just progesterone. They don't need any estrogen. There's
Right.
estrogen dominant. That's what the ketchup, the Heinz ketchup thing is.
Yeah.
And then eventually, as they hit the ovaries start to tank, then
Mm.
we add the estrogen. And so someone older, I would start with progesterone, estrogen alone before I would add a lot of testosterone, DHEA, because
Mm.
then there's, as you can tell, the variables are almost infinite and how with
Yeah.
so it's much easier to assess with some small amounts of estrogen, progesterone first, see how they do in 2 or 3 months, and then if needed, add a little testosterone, and see. And I would say more women above the age of 65 are on a very small dose of estrogen, progesterone without testosterone, but even they can benefit from small doses if appropriate.
Fascinating. Wow. Well, you've given us a lot of really great information to think about. But I think that one thing that we have not talked about yet that's always been a part of our work together that I want to make sure women hear about is what hormones are doing in our body and how they're actually excreted, because there is a really important aspect of our hormone balance that has to do with our gut health, right? And would you speak on that a little bit? Because I think this is something that you care a lot about and you've guided me really well on as well.
Thank you, Bree, because it is, so what happens is estrogen, progesterone, all these hormones in our body, they're treated by our liver just like a drug or a chemical. So we have to detoxify these. And often when women get into trouble, even with risk of breast cancer, endometrial cancer, any sort of hormone related issue, it's not that their hormones are the bad guys, it's that they're not able to get rid of the excess. They accumulate certain metabolites that can damage DNA, and that leads to bad things. And interestingly, in our world that we live in, there are loads and loads of things that mimic estrogen. They're called endocrine disruptors on our body. So a lot of times our bath and body products, our makeup, things that scents we use in our house, even atrazine that's used on corn in the Midwest, and these chemicals act like hormetic or hormone effects on our body, and it's very toxic. So it's almost worse the environment than the hormones we take, but we have to think about that. So if I'm really going deep or someone has a lot of concern, I may even go as far as to do genetic testing on their liver's ability to handle hormones, because there's a few different genetic, we call them SNPs, which just means things that you don't process normally. Like say a normal person is 100% processing, you may process it 60% or 30%. So sometimes I look at certain ways that you process hormones, and those people I might do lower doses. I might monitor them more frequently. And again, that might be the 10% of the population. So if you have a family history of cancer, especially hormone related, or you might want to get into a deeper discussion with your doctor. But at the core, what you can do is this. You can make sure that you are using clean products on your hair, on your face, on your body. Transdermal medications work for a reason, because we absorb everything through our skin. And if we're putting stuff on our skin, conventional perfumes are full of phthalates. Any non-organic produce often has glyphosate residues or pesticide residues, and all these things have a toxic effect. So I like to keep it simple. And if we just start with clean air, clean water, clean food to the best of our ability, that gives us a foundation for safe hormone replacement, because we're not getting a bunch of extra signals to our body from the food that we eat or the water that we drink.
Yes. And even without hormone replacement therapy, if our
Yeah,
gut is not working optimally, we are not going to be able to process excess. So like we talked a little bit about estrogen dominance a little
yeah,
bit ago. And I know that one of the things that can make estrogen dominance worse, even as we're losing that progesterone, maybe we're in the early stages of perimenopause, is not being able to process the excess estrogen that we do have out of our body, right? And there's a section of the gut microbiome called the estrobolome that helps to process the estrogen. And if it's not working, if it's not able to function well, it's going to send that back into our system as dirty
Mhm.
estrogen. What does that mean exactly, and how does that impact us?
So this is really big, and I'm so glad you brought it up, because what happens is our liver's always doing the detox work, and it just squirts out stuff into the bile that's supposed to be getting rid of, and that's in our stool. So if you're a woman who has chronic constipation, that alone puts you at higher risk of reabsorbing toxins from your environment or food. And even if you're on hormones and you have chronic constipation, you're going to have more trouble eliminating the same dose as a woman without constipation. So the bowels and eliminating are so crucial to this whole pathway into replacing hormones appropriately. So if we're not basically that enterohepatic circulation, which is a really fancy word for the
Did you say
merry-go-round,
entero and say it again?
enterohepatic. So it's like gut, liver.
Enterohepatic. Got it.
It's kind
Gut
of like
liver.
another way for gut liver circulation. That pathway all the time is being reabsorbed. And so if we have a bunch of toxins in our gut and we're not pooping out daily,
Mhm.
we're going to reabsorb toxins and we're going to reabsorb hormones, and we can get excessive levels. So it is a really big deal it's like fiber alone, getting good fiber from your foods, which you're pro at that with your meal plans and all the things that you do, because
But I'm
that's
an
going
advocate
to,
for it as
yes,
well
yeah,
as walking after a
yes,
meal or
yes.
walking more in general, like
Mhm.
that helps peristalsis, all these things that
Yep.
help the gut and help you have your regular movement. So
Yes.
yeah,
And that's part of hormone replacement, because if you're not moving your bowels, you are going to get more toxic. And these things
yeah,
that are helpful and beautiful could become a poison to your system.
yeah, yep, exactly. So I'm so glad that you talked about that, because it's aside from any type of hormone replacement therapy, our body has this elimination process naturally for the hormones that we already have in our
Yes.
system, our natural hormones. And so if we're not eliminating well already, and we go pile hormones on top of that, like bioidentical hormones or whatever kind of hormone replacement therapy you're using, and you're not eliminating well, you just said it so well. We're poisoning ourselves rather than
Yeah.
helping ourselves. You're turning something that's this potion into a poison,
Right.
which we don't
Exactly.
want. right? We want to take, yeah. So we talked about fiber. We talked about walking more. I think staying hydrated also so essential for supporting gut function.
Yeah.
Chewing more mindfully,
Yes.
chewing more, slowing down when you eat to help your salivary glands and the amylase and all of the things that help digestion begin in your mouth. What other like little hot tips do you have for people to help
Yeah.
them with better gut health? I just said a few.
Love it. So I think a good probiotic, I like to do spores, but there's so many good ones out there. Spores have tended to work with even my tough, difficult to treat clients with gut issues. Those tend to be real well tolerated. Um, One thing really interesting is there's a lot of natural substances that can help us on these pathways. And you can talk to your doctor about these, but some that are real common are sulforaphanes, which come from broccoli sprouts and
Hmm.
sprouted seeds and things. So that's a great place. You can buy it as a cap, but you can also sprout your broccoli and have that on your salads. Calcium D-glucarate is a type of, it helps this phase two of the liver, so processing that hormones. And we can actually see markers in the stool if we're doing specific testing for someone who isn't processing well. And we can add that calcium D-glucarate as a supplement to help them eliminate in this liver gut axis. And then a third one is DIM, DIM. And this is also a really powerful one. The one caveat with DIM is it's so good at lowering estrogen that if someone was like 65 and already having osteoporosis and already really low estrogens, that's strong enough that I probably wouldn't use it in that population, but I would if it's a 45-year-old woman on hormone replacement having a tiny bit of breast tenderness. Those are kind of the ways that you could use that. Sulforaphanes, calcium D-glucarate, and DIM. And then, of course, methylated B vitamins. Just B vitamins are crucial for this process. And things like NAC, which is really supportive for the liver as well.
So interesting as you're saying all of those. I'm remembering all the protocols we did when you were helping me heal from mold exposure, which was terrible. And that happened right at the beginning of my perimenopause journey. And a lot of those things that I needed, the liver support, all of that, it's just interesting thinking back on it now. There's that great Steve Jobs quote that was that you can't connect the dots looking forward, only looking backwards. And now, as I'm thinking back on all of the different
Oh,
things,
yeah.
how you
Uh-huh.
treated me, I'm understanding the connections that we made there and the ways that you really were trying to help support all of those holistic processes and all of those things I used in the past that I don't need specifically
Hmm.
anymore. And that really gets me back to this thing that women need access to specific individualized healthcare that has this breadth, that has this depth, that cares about these different aspects of our health and is knowledgeable in that sense, and I have been so lucky to have you in my life. And for people who don't get to have you because you have a practice, you have an amazing book. There's a movie about you. You have an incredible website with this depth of information so that people can learn more and become advocates for themselves with their own doctors. You have a supplement store where people can purchase a lot of these types of supplements for themselves. And I feel like you have a lot of amazing resources. And is there anything I left out of that? Because, well, your social media, what else did I forget to say? Your YouTube,
Podcast, but yeah, that's
your podcast,
it.
right? Your
Yeah,
incredible podcast, which I've been honored to be a
yeah.
guest on
It's
myself.
okay.
But where I was going partly with that, aside from saying, okay, ladies, we all need these resources, and here's some of what you can get from Dr. Jill. Um, and Dr. Jill and I were talking before this podcast started about, well, where else can women go?
Yes.
And I was saying, I've been researching these different companies that practice telehealth, and I'm going to read a few, and I'll of course have
Wonderful.
all these linked in the show notes. And I ran them by you earlier, Dr. Jill, because I just want to make sure that this was a good, that I wasn't going, I thought they were great, but it's good to hear your vote of
Yes.
confidence in these as well, because this is, I think, the future of that type of medicine and for women specifically.
Yes.
So here are a couple that I found. One is called MIDI, and I love MIDI. It's like MIDI, and it's a female founded company. It's all these cool women doctors, and it's telehealth company. There's telehealth options, right? And then they also will prescribe hormone replacement therapy or whatever you're comfortable with and whatever you need. And I just watched a couple videos from one of the co-founders and was just so impressed. She reminded me of you. She
Oh,
was so cool and down to earth, and like she it was all very personal for her because she's gone through the journey herself. So I love MIDI. Another one that I found, obviously, you've probably heard of Winona. I think
Oh, yeah.
Winona's been around for a little while and they're great. They also have the telehealth options. Another one I found that's down in Tampa, but they do telehealth and do quite a lot of cool prescribing is Defy. Like they're called Defy, which I like.
Love it. I
Defiance.
love
Yeah, Defy.
uh,
And then there's one called Stella. And
oh, yeah.
Stella, I thought was really cool. They also have telehealth options. They have the hormone replacement therapy options. They have a website for U.S. based patients as well as UK based
Oh,
patients. So
nice.
you can use one or the other depending. I know a lot of you guys are in the UK that listen to my podcast. Thank you so much. And then I was thinking about my people in Australia. There's something called Clinic 66. And if you're looking for options for yourself in your country, I think just using some of these keywords that Dr. Jill and I were talking about today on this podcast, like look for things like telehealth options for hormone support in menopause. I feel like I did that myself at different times and I put it into different countries to see like where are they doing this stuff. And then you just read what's on the website and then you just kind of have to follow the threads and see where it's going to work for you. And I've noticed the US based ones, some of them have limitations by state that
Yeah.
they're going to treat in. Do you know much about that? Or like you know, I know you're not going to know what each person's going to do, but what are some of the limitations that you do know of in the
Yes,
states?
medical doctors are still licensed by state, so you really typically are, unless someone comes to see me in Colorado, I'm I have to be more careful about who I treat outside of the state. So that's a whole deal. One other thing that might be super helpful is if you have a compounding pharmacy in your area, that's a great place to call because they know what physicians in your area are prescribing hormones. And usually the compounding pharmacies also know who really know, because they're going to be, like for me, they know I prescribe a lot of hormones. I talk to the pharmacies all the time. And so a great way is if you know there's a compounding pharmacy in your area, you call them and say, hey, what doctors do you know in my area that are doing this? And that's another nice way to get in your area someone who is legit, and your compounding pharmacy will typically know who that might be.
And in order to find a compounding pharmacy, would you just Google compounding pharmacy in my area?
Yeah, yeah.
Yeah.
There's a PCCA used to be the biggest organization that certified compounding. So PCCA, I don't know exactly what it's something Compounding Pharmacies of America, but
Mhm.
if it's just pcca.org, I guess, I don't know the exact site, you should be able to find compounding pharmacies. But yeah, you can also just Google compounding pharmacy in my area.
That's great. And I think, I mean, and there are many more than the ones that that short list I gave you guys.
Great.
I love all these options that are out there for us. And I feel like it's going to get better. There's going to be more and more of them, hopefully, over time. But really just having this conversation, asking for what you need, advocating for yourself. You and I had a conversation a month or two ago, and we were talking about how you said today, like some doctors, you feel like they gaslight their patients, and it's because they don't know, they don't have a
Right,
clue. And I
right.
said on a podcast where we were talking about this, I was like, I feel like the doctors don't mean to be jerks about this stuff. They just don't know. And if they knew, they would maybe try to get more information, right? Because they
When
all
you
have
think
the
about like
mom,
even me, if I graduate from med school and I'm told that this is dangerous and then I never look and never learn, which a lot of docs stop learning after,
right?
then why wouldn't I say, oh, no, don't do it? That's what I heard 2001, which is old news now, right? So that's a lot of them just don't know the latest data and the
If we were
safety.
to expect science to be this static thing and we can only take whatever's been said before, I mean, we'd never have any women specific
Right,
studies, right? Like we'd
right.
have nothing. We have to allow science to be this evolving, like learning process. That's what science is. You know, they're observing data and they're reporting on it, and over time they get better and better at their methods, hopefully. And
Yeah.
I mean, just seeing not them, but seeing the more specific studies done on women specifically. I mean, it's like a revelation. You're like, well, why didn't we do that before,
I
guys?
know. It's about
Where have you,
time.
right? Don't you all have a mom? Like, don't you have a
Yeah.
sister? Don't, yeah. So it's great to see that. And I'm glad we're having these conversations. But Dr. Jill, I just want to thank you again so much for taking the time to talk about all of this today. We covered so much in a short time. And is there anything that I didn't say or didn't ask you that you'd want to make sure to get across just in case?
No, just thank you for the wonderful work you do in the world. And thank you for having me on. It is always so much fun. It's like having coffee with a friend. And
Same.
if you're out there and you're suffering for hormones, you don't have to. And there are just, I love the resources you gave. There are so many people who do understand this. And I would just continue to search until you find those answers.
I would agree. I would agree with that. Yes. And thank you so much for your work. And I'll have links in the show notes, of course, and with this video so you guys can follow up with Dr. Jill and get all of her incredible resources. She has so many. You've done so much work for women and so much work for your patients in general, men and women. Thank you again so much for being here, and we look forward to talking to you again. Thanks. Thanks so much. And hey, Rockstar, thanks so much for listening today. It's been great to spend time with you. I hope you learned something that's helpful, and I'll have all those links to the things that we mentioned, as well as a couple of books and resources Dr. Jill shared with me that we didn't get a chance to talk about on the show. Be sure to check out the show notes page for this episode over on my blog at thebettyrocker.com in the podcast section for all of those links. And I hope that wherever this finds you, you are taking great care of yourself. Till next time, I'm Betty Rocker, and you are so awesome, blossom, and amazing. Bye for now.
This podcast is for information purposes only. Statements and views expressed on this podcast are not medical advice. This podcast, including Brie Singer, Betty Rocker Inc., and the producers disclaim responsibility for any possible adverse effects from the use of information contained herein. Opinions of guests are their own, and this podcast does not endorse or accept responsibility for statements made by guests. This podcast does not make any representations or warranties about guest qualifications or credibility. Individuals on this podcast may have a direct or indirect financial interest in products or services referred to herein. Before starting a new exercise, fitness or health protocol, or if you think you have a medical problem, always consult a licensed physician.